Okay, you can go ahead.
Okay.
You
Good
have
morning.
15 minutes. Mm.
Okay. Good morning, teachers, senior colleagues, and colleagues. My name is Dr. Nkanta, and I'll be attempting to discuss the question 5 of this recall. The question is a female patient with rheumatoid arthritis who has been on methotrexate, had 2 previous doses of rituximab. During the current infusion of rituximab, the patient develops itching and swelling of the lips. Blood pressure dropped to 80/60 millimeters of mercury. So the first question, what is the diagnosis? My diagnosis in this patient would be that of an acute drug-induced angioedema presenting in anaphylactic shock. The second question, what is the mechanism by which rituximab is causing these symptoms? Well, I consider majorly 2 mechanisms by which rituximab is causing these symptoms. Number 1 is a type 1 or immediate hypersensitivity reaction, likely immunoglobulin E mediated, whereby mast cell degranulation causes release of mediators like histamine. And then 2, which has been implicated specifically in monoclonal antibodies like rituximab, where there have been case reports, is the cytokine release syndrome, where symptom complex is associated with the use of many monoclonal antibodies. This usually results from the release of cytokines from cells targeted by the antibody, as well as immune effector cells that are recruited to the area. And then this causes the immune mediators recruited to the areas usually lead to vasodilatations and then fluid seeping out of the intravascular space, causing the systemic symptoms noticed. Question C says, list other clinical features of this condition. Well, on the skin, you can have urticaria, which usually is involvement of the upper dermis, where you now have swelling of the skin and hives and itching. You can have tongue swelling. You can have edema of the larynx, which causes airway tightening, can lead to voice change, and in severe cases can cause airway obstruction. If the intestines are involved, from mucosal edema, you can have severe abdominal pain, and then sometimes it can mimic intestinal obstruction in severe cases. So question C says, how will you manage this patient? Acute angioedema is a medical emergency and should be treated as such. The goal of treatment is to maintain a patent airway, to relieve symptoms, and then also to stop disease progression. If not, it can ultimately be fatal. Management is multidisciplinary. I will likely involve the ENT surgeons, clinical pharmacologists, the immunologist, and then even the intensivist. Patients should be managed in a high dependency unit or in an intensive care unit in very severe cases, although there have been cases where if symptoms are not very severe, patients can be monitored and then discharged after relief of symptoms. This patient should be nursed in a supine position with both lower extremities elevated, especially in this patient that is presenting in an anaphylactic shock. This will cause increased venous return and then help in blood pressure elevation. We'll take a very quick history and physical examination. History will be if patient has had previous symptoms, previous allergies, and if he has reacted to the offending agent before, family history of allergy, and then a quick physical examination to assess for severity of symptoms, especially the airway. The offending agent will be discontinued. Since this patient was on rituximab infusion, the infusion should be clipped off immediately. And then the ABCD of resuscitation will be instituted immediately. Oropharyngeal airway insertion will be instituted. Airway management is very key in this patient because it can lead to severe laryngeal edema, airway obstruction, and even asphyxiation. So I will want to do a cricothyroidotomy for this patient, which is less traumatic than a tracheostomy, which is usually done in the theater. So by the bedside, I would like to do a cricothyroidotomy if there are worsening airway symptoms in this patient, which are symptoms of severe laryngeal edema and airway obstruction. This patient came in shock. I will commence intravascular volume expansion with crystalloids. The volume of fluid replacement, the amount of fluid replacement given to this patient will be tailored to take into consideration the patient hydration status, blood pressure. This is a patient that I would like to monitor central venous pressure closely to ensure adequate correction of his fluid status. Vital signs will be monitored closely. The urine output to monitor closely. Patients in shock are likely want to pass urethral catheter to monitor urine output closely. I'll also administer IM or subacute adrenaline promptly. This has been found to be the treatment of choice in patients with angioedema. The dose will be at a dose of 0.01 per kg to a maximum dose of 0.5 milligram of the 1 in 1,000 formulation. Sites of administration, usually the mid-outer thigh, because it has been found to have a higher plasma concentration. Administration of deep IM adrenaline has been found to have a higher plasma concentration, and then with less side effects. The IV route has been found to be unpredictable and can lead to side effects like cardiac arrhythmia. Those may be repeated at 5 to 15 minutes if no response, or if there is an inadequate response. So you can repeat the dose if the response is not adequate. An adrenaline continuous infusion at the rate of 0.1 microgram per kg per minute if there are no or inadequate response to repeated IM or to repeated IM administration and intravenous fluid. So if the blood pressure does not appreciate, or if symptoms of worsening anaphylaxis goes on, I would like to commence this patient on IV adrenaline infusion. Adjunct medications that will be given to this patient will include IV glucocorticoids, usually in severe symptoms or in patients who has a comorbidity of asthma with significant persistent bronchospasms. Antihistamine, I'll also give antihistamine that will relieve itch and hives. The H1 antihistamine will include cetirizine at the dose of 10 milligram over 1 to 2 minutes. Diphenhydramine at the dose of IV 25 to 50 milligram over 5 minutes will be given. The H2 antagonist, famotidine, can also be given at the dose of 20 milligram over 1 to 2 minutes. For those with persistent bronchi or worsening respiratory symptoms, you can also nebulize this patient with the beta-2 agonist for relief of bronchospasm. Oxygen therapy, if patient is in respiratory distress or patient is desaturating. This patient came in shock. And so you want to rule out the effect of shock on the kidneys. And so I would like to do serial serum EUCR because creatinine is a poor marker of kidney injury. So It might not be obvious until maybe it's 24 to 48 hours post admission before kidney injury is apparent from the serum creatinine result. How will you prevent the recurrence? If this is because there's a suspected IgE mediated reaction here, there's always a chance that this patient will still have the same symptoms if given rituximab the second time. So I would like to switch this patient to a more tolerable and effective alternative. The tumor necrosis factor receptor antagonist, etanercept, has been used at a dose of 50 milligrams weekly in addition with methotrexate, and has been found effective in patients with rheumatoid arthritis. Although there has been reports of a reduction in the symptoms with pre-medication before administering rituximab, pre-medication with antihistamine and steroids have been found to reduce the subsequent reaction to rituximab. And then there have also been reports of control of symptoms with slow administration of rituximab in patients. But I would like to switch these patients to etanercept. So this is my outline for a quick summary of angioedema.
You have about 3 minutes, please.
Okay, so there's been a case report of rituximab-induced angioedema in a 60-year-old patient managed for Sjogren's syndrome in India. Cytokine storm mediated reaction was actually implicated. As an introduction, angioedema was first described in 1586, can also be called Quincke edema, giant urticaria, and angioneurotic edema. Usually defined by pronounced swelling of deep dermis, subcutaneous or submucosal tissue, usually different from urticaria, where the superficial dermis is typically involved in patients with urticaria, although you can have angioneurotic edema coexisting with urticaria. The incidence varies depending on the study population. For patients with angioedema caused by intravenous immunoglobulin, the incidence is about more than 40% of chronic angioedema is idiopathic. Trauma, surgical procedures, and stress are common specific triggers for angioedema attacks. There could be angioedema with identified with etiologies, food, physical stimuli like food. ACE inhibitors are very common with NSAIDs as an etiological factor for angioedema. The C1 inhibitor deficiency, inhibitor deficiency has also been implicated. There are angioedema with certain syndromes, like in glitch syndrome, where we have angioedema, episodic angioedema with eosinophilia, and then in Wells syndrome, where you have granulomatous dermatitis with eosinophilia. You can have the non-allergic edema, which can be inherited, like the hereditary angioedema. So this is a pie chart showing the different prevalence of angioedema, recurrent angioedema with urticaria. The pathophysiology, angioedema results from a rapid increase in local vascular permeability in the subcutaneous or submucosal tissue. Histamine and bradykinin have been the mediators that have been implicated the most. Leukotrienes may also be important, usually in patients with NSAIDs. Mast cells and basophils are the primary source of histamine. So mast cells and basophils activations with subsequent histamine release may trigger, may be mediated, may trigger release, which may be mediated or unmediated by immunoglobulin E. There could also be non-immunoglobulin mediated mast cell degranulation, what you find in autoimmune disease or in patients with idiopathic angioneurotic edema. In patients with the C1 inhibitor deficiency and angioneurotic edema, this usually causes regulation of bradykinin. So when it is deficient, it causes unregulated checks and activation of the kallikrein kinase system. The clinical features, family, you have to take a very good history, family history, prior personal experience of angioedema. Has the patient had new food or medicine recently? You have to also find out potential triggering or exacerbating factors and concurrent medical condition. Exam finding, you have to typically dwell on the airways. There could be swellings on the lips, on the arms, tongues, and feet. Genitalia could be involved. Examination, laryngoscopy might be indicated to assess for laryngeal vocal cord involvement. Bronchi or might find bronchi on auscultation. This is a patient with angioedema, her normal look, and then during the attack. And this is a patient with swollen tongue. Investigation, diagnosis is mostly clinical, but in some cases you might want to investigate, especially if you have recurrent angioedema with urticaria. You want to do your C4 level, your C1 esterase inhibitors, both qualitative and quantitative measurements. And then if in suspected specific problems where you think there are specific problems causing this condition, you might want to do some workup, hepatitis B and C, rheumatoid factors, and cryoglobulins in cases of autoimmune cases. Imaging, plain abdominal X-ray, especially if you suspect internal organ involvement. A plain abdominal X-ray will give you a stack coin or a thumbprint appearance of the intestine. The radiograph of the neck will show soft tissue swelling. Treatment depends on the etiology. Management, as I said earlier, should be multidisciplinary. Pulmonologist, otolaryngologist, anesthesiologist. Airway protection is most important. If intubation is required, ICU admission is recommended. Like I said earlier, surgical airway might have to be created. Likely, the cricothyroidotomy is preferred because it can be done at the bedside, not necessarily in theater. Discontinue all offending agents, ensure circulatory support. IM adrenaline, as I said earlier, 0.5 milligram, the 1 in 1,000 dilution should be administered early. Antihistamines are also useful. Steroids, bronchodilators are adjunct, especially in severe cases. Immunomodulators like omalizumab have been used in recalcitrant cases, especially in the idiopathic, urticarial, and angioedema cases. In patients with acute hereditary angioneuritic edema, attacks can be treated with infusion of C1 inhibitor at the dose of 20 units per kg. There are other medications that have been tried and approved by FDA. Ecallantide, icatibant have been tried. Complication, airway swelling can cause asphyxia and death. Airway edema can make intubation difficult and with the risk of vocal cord damage. Angioedema is associated with severe pain and disfiguration. Prevention, avoid triggers, keep food diary, educate patient on the common signs, educate patient on the use of an EpiPen. Typically, this is what is done. Patient should go about with an EpiPen in case of an emergency. So these are my references. Thank you for your attention.
Thank you, Dr. Nkanta, for the presentation. So the class is open for contributions, questions, clarifications. You can raise your hand electronically and make your contribution. And you can also type in the chat box. So questions and clarification. So while we're waiting for that, Dr. Tanimu is saying, what is the specific name they call it with respect to rituximab? Dr. Linda is saying, thank you for the presentation. I feel your approach for management should have started with the life-saving steps first before the other things you do, since this is an emergency. Dr. Esther said pre-medications will reduce will prevent reoccurrence. Those are the. So Dr. Tanimu will say, what is the specific name it is called with respect to rituximab? That's the major question from the chat box.
I think I mentioned it, that it is called the cytokine storm syndrome. and it's typically in respect to most of the monoclonal antibodies. That is the mechanism of angioedema in the monoclonal antibodies. I don't know if it has other names. I think it's called the cytokine storm syndrome, something.
Okay. Dr. Ekele is saying, how do you differentiate from anaphylaxis?
Well, this is a type of anaphylaxis. This is a type of anaphylaxis because it is an Ig mediated type 1 hypersensitivity reaction. So it can also pass as a type of anaphylaxis.
Okay. Okay. Dr. Remigus, good morning, sir.
Yeah, good morning. Thank you for the beautiful presentation. Let me just start by trying to answer that last question. Actually, it's part of the things I noted. This patient actually had anaphylaxis and not angioneurotic edema, okay? And sometimes we make the mistake. Angioedema is termed, in quotes, a local reaction. But by the time it becomes systemic, that's when you call it anaphylaxis. Okay? So by the time this person is coming in shock, then this is definitely anaphylaxis, no longer angioedema. Okay, so that shock is what makes it anaphylaxis. So this is anaphylaxis. I expected you to talk more about anaphylaxis. It's like a spectrum from angioedema to anaphylaxis or anaphylactic shock. Okay. So this was more of anaphylaxis than angioedema. Then in the pathophysiology, it's very important to mention, and if you note from the question, this was not the first time the patient was getting the rituximab. So it usually occurs after a re-exposure. Okay, so the initial exposure does not cause anaphylaxis, usually after a re-exposure. So the initial exposure will just sensitize the patient. Sometimes it might take 2 or 3 before the reaction occurs. Okay, so I wanted to add that. Then for the, yeah, you are very correct. The treatment of choice is IM adrenaline, 1 in 1,000 dilution. Okay. Sometimes it might even be better to give that first before you start talking about volume expansion. Okay. So because that's, if you are sure that this is anaphylaxis, you can even give that, or you can be giving it concurrently with your volume expansion, whichever. They need all of them. But that IM adrenaline is practically the most important life-saving medication that you can give them. So then, yeah, IV can be given. Usually it's indicated when you want to give a lot of doses, several doses over a long time. And the formulation for IV is 1 in 10,000, not 1 in 1,000 like the IM formulation. I don't know if I missed out ICU admission. ICU admission can be very important in this patient. Sometimes it may require either non-invasive or even invasive ventilation. Like you've already mentioned, the cricothyroidotomy and all that, which was also important. Then I think the last thing I wanted to just chip in, although we don't use the term any longer, is anaphylactoid reaction instead of anaphylaxis. Anaphylactoid is just more of if it is not IG mediated. So it's not always IG mediated, okay? But most often times it is IG mediated. But the ones that are non-IgE mediated are the ones that were formerly called anaphylactoid reactions, but now everything is just called anaphylaxis, whether it is IgE mediated or not. But most of the time, I think about 90% or so of the time, it is an IgE mediated type 1 hypersensitivity reaction. So thank you for the presentation.
Thank you, sir,
Okay.
for
Thank you, sir.
the wonderful contribution. Okay, back to the chat box. Okay, Dr. Emmanuel said, I thought the diagnosis is anaphylaxis. So, yeah, Dr. Remigos has clarified that. Okay, Dr. Paul said, discharge advice for future episodes will be medical alert bracelets, and I am self-administered adrenaline. So those are the advice you can give. Okay, thank you for your present. Dr. Jamila said, thank you for your present. Please, can you clarify how to prepare the 1 in 1,000 adrenaline for IM administration, or does it come already prepared?
There are some that come already prepared, and then there are some that you have to prepare. Adrenaline comes as in a 1 ml, 1 ml vial. It's a vial of 1 ml. So you can draw the 1 ml and then make it up to 10 mils, and then you give IM. I think that's how it's given. That's how it's made up.
Are you preparing 1 in 10,000 or 1 in 1,000?
1 in 1,000, sir.
So by the time you are adding more water, you are diluting it further now.
Okay.
So maybe you are talking about preparing the 1 in 10,000, not the 1 in 1,000. So, but most often times it actually comes like that. So you just have to check and be sure that that's the one that the preparation that you have. Okay. So, but I think it's when you want to give the IV, you can now dilute, depending on the one that you have.
Okay, sir. Any other comment? Dr. Ayodiji, are you ready for your own presentation?
Doctor, can I be heard?
Yes, you can be heard.
Yeah, so I didn't want to speak up earlier concerning the question. Yes, I'm on call. I didn't want to speak up earlier. I want the participants to take note of this error. As you think everybody was carried away. Okay. Come, your school bag. Everybody was carried away with Andre Idima.
Please, Dr. Nkata, can you move out this your slide? This is your slide.
Okay.
Move out of this
slide.
Yeah.
Okay. Careful. So please, participants, that's why Chief Cookie said at that time. All these questions should have been answered by those going for exam. So that when somebody is saying something that is wrong, you guys will quickly pick it. They are all going for exam. If the facilitators now, maybe we are distracted or something, because most time we are multitasking. If you are distracted and the guy just finished saying all the things you want to say, you go for exam. After you're going to be saying it's Andrew Idima, and even though the management is the same, but every mark matters. All these 0.05, 0.01, all of them matters. Get all of them, pick all of them, pick every single one of them, so that in the long run, you're not even scared at all. So, but I must appreciate him. It was a lucid presentation. But one other comment I don't want to dwell on that. Chief Remigus have said that already. Then the second thing I wanted to comment about was his management. It was a little here and there. I don't know, Dr. Nkata, please, when are you going for exam?
I'm going for this exam.
You're going for this exam. Then I don't know, have you been participating actively in the class?
Well, yes, I have.
Okay. So we need you to practice more how to answer questions, especially management questions. You have few minutes to quickly list out your line of thought. I know this is presentation, maybe that's a little relaxed. You're not time bound and so when you're talking about multidisciplinary management, you just say it in passing. You don't go into detail like tracheostomy, ENT. No, actually, in reality, we should be the ones doing some of these things. The multidisciplinary, some of the examiners will even tell you, oh, doctor, some of them don't even like it. Why some do? But I will not discourage you. Please say it. You don't know the ones that like it. Just say, but say it in passing. This is an emergency, multidisciplinary airway. I want to check airway, make sure patient is patent. If it's not patent, I want to quickly pass tracheostomy through all parts and airway. You understand? You just quickly say it. Actually, we are the ones that are supposed to pass all these things. So it's not ICU guys and ENT guys. We are the ones that are supposed to do it. So of course, you might say some of these things, some of them, especially those that are not practicing this country, because some of them are trying not practicing in this country. They'll feel irritated. This doctor is lazy. So you want to give everything to ENT doctors. So just say, do this. Or if you are a little careful, if you don't want to be out there, just say, I would this should be done. So in case you say, I don't want to say I will, this will be done, this will be done. But overall, it was a wonderful presentation. These were just the two areas I had issues with. Thank you so much.
Okay, thank you, ma'am.
You're welcome.
Okay, Dr. Aditi, can you Dr. Nkata, can you stop sharing your slides so that Dr. Aditi can start sharing his slides?
Good morning, teachers. Hello?
Yeah, we can hear you. Can I put it on a slideshow? Yeah.
Okay.
Remember, this is practice question. Please, practice question.
Good morning, teachers. Good morning, colleagues.
Good morning.
I'm taking the question. Can I be heard?
We can hear you.
Yeah, I'm taking the question 7 of the May National last year.
Oh, practice question.
Practice question, okay. A 30-year-old obese lady in the obstetric ward had a CS a week ago. She was walking to the bathroom this afternoon when she fell, and her SpO2 was found to be 92. Artery was 110 beats per minute. Respiratory was 30 cycles per minute. The BP was 90/62 millimeter of mercury. The chest X-ray was normal. What is the most likely diagnosis? B, how will you confirm your diagnosis? And then C, what other investigation will you do? And state the reason for each investigation. D, state 3 scoring system that can predict your likely diagnosis and use the score to risk stratify the patient. And E, how will you treat the patient? So what is the most likely diagnosis on account of the presentation, the sudden respiratory distress, and then the fact that the patient just had the CS, the most likely diagnosis, and even the desaturation to 92%. The most likely diagnosis is acute pulmonary edema. Acute pulmonary embolism, I mean to say. How will you confirm your diagnosis? Of course, a CT pulmonary angio, of course, will confirm the diagnosis. What other investigations do you want to do? Want to do an ECG, which may be normal, but most commonly they could have a sinus tachycardia. You could also have evidence of RV strain, right bundle branch. You could also have the S1, Q3, and T3. Chest X-ray can also be done. You can see a focal oligemia. You can also see wedge shape opacity, that is. You can also see evidence of a large descending pulmonary artery. Of course, echo can also be done, in which case you see evidence of RV enlargements. RV dilatation can also be seen. You can also see Marconi signs. That is when you have mid-RV wall hypokinesia, sparing the apex. You could also have a 60-60 sign even on echo too. You could also have a D sign. A CTPA, like I said, can be done. You can do a VQ scan, in which case you can see a filling defect too. Of course, a Doppler can be done in case they have a clot even in situ in the deep base of the leg. But most majorly, they do not have a thrombus. However, that does not rule out a PE. You can also do an ABG arterial, which is not specific. You can see hypocapnia, hypoxemia too. D-dimer can also be done, which is highly sensitive. It has a high negative predictive value. However, for those who are low risk, you want to do a D-dimer. For patients with a very high risk patient, even a low D-dimer does not rule out a P. State 3 scoring systems, and use this course to looking at these patients, we can use the Wells or the revised Wells score, and the index patient will go to score a 3 based on the fact that he just had a surgery, that is 1, and then the fact that the heart rate more than the 100, that has another score of 1, and then the fact that P is likely score, it gives another 3. So you have the 3-level scoring with the revised Wells score. You have the low, intermediate, and the high risk. While you also have the two-level scoring, in which case you have P, E likely, P unlikely. You can also use a Geneva revised scoring system, and the patient will also have a score of 7 too, which is intermediate probability. You can also have a pulmonary rule-out score, in which case this patient, you have 8 parameters. Based on the fact that this patient has a surgery, that's 1. The heart rate also gives the patient 1, and also the tachypnea too. Patient also has 1 too. That's the Wells criteria, the original and the revised version. The original one has like a 3-level score, low, intermediate, and high risk. And then you have the 2-level score, PE unlikely and PE likely too. And then you have the Wells and the revised Geneva score too, in which case you have the low, intermediate, and high risk too. And you also have pulmonary embolism rule-out score. I said you have like 8 criteria, and based on the pulse, our patients, the index patient has the pulse rate of 110, which is more than 100. So the even desaturation was the 92, less than 94. And then the fact that he had a restraint surgery, so he had 3 out of 8 too. So that makes a P more likely here too. So what are the different treatment options? That will be determined by the presence or absence of hemodynamic stability or instability based on the clinical evaluation. You also want to determine the severity of the pulmonary embolism, that is into the high risk and intermediate and low risk. I mean high risk, but the index patient fall into intermediate risk. You also want to determine the pulmonary embolism severity index score for prognosis. Presence of RV dysfunction on the echo and everything. So these are the early mortality risk score for these patients, can be into high, intermediate, and low risk. And these are the various parameters: hemodynamic instability, clinical parameters, RV dysfunction on echo or CTPA, the elevated cardiac marker, which is an evidence of RV dysfunction. The treatment option for acute phase, you have the reperfusion therapy for high-risk pulmonary, and you have the systemic thrombolysis. You will have also a catheter-directed thrombolysis too. just to reduce the side effects of the systemic side effect of the thrombolysis. We also have a surgical embolectomy too. How will you treat the patient? So just like I said, there are three different options. You could have for high-risk patients. In addition, are there evidence of hemodynamic instability in which you want to correct that even while you're giving systemic, provided there are no contraindications to systemic thrombolysis? Of course, for a patient who have maybe with risk of bleeding, to reduce that, you could do a catheter-directed thrombolysis too. Or if there are bleeding risks too, which you can't use thrombolysis, you could do a catheter directed to thrombolectomy can be done too. And these are the provisional treatment thrombolysis and the dosage that can be used. For intermediate risk embolism, for most cases of without hemodynamic compromise, you could use a parenteral anticoagulant. You have the low molecular weight heparin can be used. The dose as stated here. You could also use for the non-intermediate risks, non-vitamin K can also be, the NOACs can be used, and the doses are stated there. Rescue thrombolysis for those with hemodynamic deterioration, which I earlier said. The low-risk patients too. So I'll just take a brief slide on the pulmonary embolism using the following outline.
You have less than 5 minutes, Dr. Ayo.
Blockage of one of the pulmonary arteries by any material from distance, which could be from thrombus, air, or other gases. It's caused mainly by blood clot that travels from leg or rarely from other parts. Blockage of one of the pulmonary arteries by dislodged thrombus. You could have a DVT which could be the risk factor for the pulmonary embolism. And then when you 90% of PE originates from the legs or pelvis where blood has become stagnant. 50% of patients with DVT have evidence of clinical PE. Most importantly, DVT is diagnosed in 70% of patients with angiographic confirmed PT. Most PE-related deaths do not appear to be due to a failure of therapy, but more to failure of prevention and early recognition. Epidemiology, and no exact epidemiologic data is available. The incidence of PE is estimated to be up to 60 to 70% per 100,000 population. And that's of the venous thrombosis, approximately 124 per 100,000 general population. The European guidelines for diagnosis and managing of PE reports annual incidence rates of venous thrombosis and pulmonary embolism of 0.5 to 1.0 per 1,000 inhabitants. After coronary artery disease, stroke, APP ranks the third among the most common types of cardiovascular disease. While clinical data indicate most of the cases of PE occur at 60 to 70 years old, autopsy data show highest incidence among individuals with 70 to 80 years of age. If untreated, AQP is associated with a significant mortality rate as high as 30%, where death of undiagnosed treated PE is up to 8%. It's been said to be associated with major malignancy. It's also a risk factor for the PE, various malignancy with the prevalence are showed here. The three primary influences predispose the patient to blood clot formation, and this forms a well-known the virtuous triad. That is, you have endothelial injury, stasis, turbulence of blood flow, and blood hypercoagulability. That endothelial you have from local trauma, previous thrombosis, inflammation, smoking, advancing age, proud pulmonary embolism, central venous cannula placement within the past 3 months, venous stasis, immobility from stroke, in bed, congestive heart failure, local pressure, tight POP, venous obstruction, hypervis prostate from polycythemia rubra myelofibrosis, or hypercoagulated state, factor V leading mutation, protein C, obesity, antiphospholipid, malignancy, pregnancy, The other common ones are listed here. And then you have the other risk factors also listed. As a way of pathogenesis, following the three triad, hypercoagulative state, venous stasis, venous injury, the blood clots that develop in the vein can dislodge and migrate to the inferior vena cava, adhere to the right atrium, right ventricle, and lodges in the main branch or even the other or segmental branches of the pulmonary artery. And as such, your clots occlude the pulmonary artery and or the right ventricle to the pulmonary, increase in pulmonary and the right ventricular pressure of the right ventricle, the decreased coronary perfusion. And when this happens, you have hypotension to ensue, you have increased troponin. Clinical progression vary from the sudden onset to a gradual progressive disease. A diagnosis should be sought in any patient with respiratory symptoms unexplained by alternate diagnosis. Symptoms are non-specific. High index of suspicion is required. Clinical signs, symptoms of PE, tachypnea, like in these are index patients, in almost 96% of people have raised loud second, that is P2, like 53% of people have tachycardia, like even the index patient have too. They also have fever too. Could be diaphoretic, RV, S3, S4 can also be had. You can also have clinical signs suggesting thrombophlebitis. You have a lower extremity edema, but this is fine, just about 87. You have a cardiac like a TR murmur. Patient can also be cyanosis. We have evidence of a DVT, which are shown here. There are screening tests. They are not specific. They are not helpful in pulmonary embolism, although they may suggest another diagnosis. These are listed here. The routine tests, you want to do a D-dimer, full blood count, arterial blood gases, because of the, we do serum troponin, so because of the RV strain, RV dysfunction, the brain arthritic peptide can also be. When you do a chest X-ray, like I said, you can see focal ligamia. You can also see opacity. The Y-shape opacity can be seen. That's often hump sign too. There are other signs, pallor sign, obvious descending pulmonary artery. You could do a CT pulmonary angio, which is the gold standard too. And then you could do a Doppler ultrasound, which case there's loss of compressibility due to the clotting situ. An MRI.
Dr. Iro, can you round up in 1 minute, please?
Okay. I've talked about the chest X-ray. An echo, of course, I've talked about the echo too before. Evidence of RV enlargement, Marconi sign. This is like a CT PA done, which case you have an thrombus in the main one of the branches of pulmonary artery. That's what you have a clotting situ. Diagnostic D-dimer has a high negative predictive value. However, in a very high risk patient, a negative does not rule out differentials IMI because they also present with chest pain, exertional chest pain. But in addition to this, they have, of course, the elevated troponins, and of course, you have ECG ST elevation in the leads. Leads. We also have reciprocal changes too. Can also be found too. Stable angina is also a differential. They have a chest pain that is not relieved with rest, or when you have a new onset worsening chest pain too. However, when you do a troponin, be normal. A patient with anemia is also a close differential. They have a difficulty breathing, fever. They could have pleuritic chest pain too. COPD, have breathlessness, previous exposure to dust or fumes, smoking history. Some of them will have a nicotine, CCF, orthopnea, PND, and can also be patient. Asthma too is also a differential, and then pericarditis.
Dr. Ayo.
Yes.
We'll look at the slides later, so that we can give room for contribution before our time.
Okay. Thank you.
Comes on. So please, thank you, Dr. Ayo, for your presentation. We welcome contributions, questions, clarifications.
Thank you.
Yeah, you're welcome. All right, Dr. Ekele in the chat box says, thanks so much for the wonderful presentation. I think the modified well score should be 6. Heart rate greater than 100 is 1.5. Recent surgery is 1.5. Alternative diagnosis less likely than P is 3.
Okay, thank you.
Yeah. Okay. Okay. Dr. Jennifer is just buttressing what Ekele said. She said you use the revised well score. So any contributions, any questions, any clarification? You can speak up. Dr. Eke. You can go ahead.
Okay, good morning, my teachers. Good morning, class rep. And thank you, sir, for your presentation. I just want to make some contributions, especially based on the changing guidelines that we now have. Okay, first of all, I don't know if you had any classification for PE, but previously PE was classified into massive, submassive, and then low risk. But currently, the new classification classifies it into high risk, intermediate high risk, and then intermediate low risk, and then finally low risk. And that classification is based on what the patient presents with. So if a patient presents with hypotension that's hemodynamically unstable, and then the patient has evidence of right ventricular affectation on echo, that means you have the McConnell sign 60-60, or you have the D sign, plus the presence of an elevated troponins and BMP, you're classified as high risk. Now, if you have your hemodynamically stable, but you still have evidence of right ventricular affectation, and then you have raised troponins and BMP, you're classified as intermediate high risk. And then if you have normal hemodynamic status, and then you have either right ventricular findings on echo, or you have cardiac troponin elevation or BMP, you're classified as intermediate low risk. And then for low risk, there's no hemodynamic instability, and then you don't have those findings on echo, and you don't have elevation of those enzymes. So it's also important to request for those enzymes to help you stratify your patient into the new stratification. And then now, based on this new stratification, will guide your treatment. So if a patient is high risk, that's when you will go for the treatment he mentioned, the thrombolysis. You may also want to do catheter-directed embolectomy. You may also want to do pulmonary thrombo-end atherectomy, depending on if the patient is high risk. Now, if you have a patient that is intermediate high risk, then there have to be a conversation between your cardiologist and everyone to decide whether we are still going to do thrombolysis for this patient, or we are going to just stay with our normal anticoagulant. Then if our patients are low risk, then you have to go with the anticoagulation that's using either the low molecular weight, or you're using the factor 10 to anticoagulate the patient. Then another difference is in the guideline treatment, because before now we used to say provoked and unprovoked. So if the condition is unprovoked, we'll anticoagulate the person for life. If the condition is provoked, we'll anticoagulate the person for maybe 3 to 6 months and then leave it at that. But the new guidelines now have your anticoagulation based on the percentage that the patient has. So there are certain conditions that are being classified as greater than 3%. Sorry, first one is less than 3%, where the patient has to be anticoagulated for 3 months, and then you reassess the patient. Then those between 5 to 8, intermediate risks, you now have to do what we call extended anticoagulation for them. That's after the anticoagulation for 3 to 6 months, you now have to reassess them and then know if you're going to extend the anticoagulation or not. Then those greater than 8% are now known as high risk, like our cancer patients. Those are the ones that now fall into that very prolonged anticoagulation. So the new guidelines, we are no more using provoked, unprovoked. We are now using based on their risk assessment. If you're low risk, less than 3, if you're intermediate, 5 to 8, or if you're high risk, greater than 8, that would determine how long you'll be anticoagulated. And then it's also important to note that other anticoagulants, especially in our environment, can be used. So we may not always go for those very high cost ones like the factor 10. So we can also use other anticoagulants like our old warfarin, but just maintaining the INR between 2 to 3, informing our patients or counseling them on vegetables and all of that can co-interact. So it's good for us to look at the new guidelines. Thank you.
Thank you.
Thank you, Dr. Ike, for a wonderful clarification and contribution. Any other contributions? Okay, let me go to the chat box while we wait for. Okay, Dr. Paul saying, thank you for your presentation. The risk stratification will guide treatment. Okay. The prognosis depends on the presence of shock, right ventricular dysfunction, PE coexisting with DVT, pulmonary embolism severity. Index can be used to predict 30-day mortality. All right, Dr. Esther is saying, Dr. Ike, if you can share the new guideline on the WhatsApp page. Okay, is there any other contributions before we hand over to our teachers? The time is well spent.
Hello, Dr. Atta.
Yes, ma'am.
Thank you for anchoring. Thank you so much. I know it has been easy on you since by now we'll have found an assistant for you. Just that the national guides are here to submit the application. We need somebody that have already applied for the